Welcome back, guys. In this video, we'll cover everything you need to know about mandibular motion and articulators. And we'll begin our discussion with reviewing Posselt's envelope of motion, which you guys should already be somewhat familiar with. The lowest point of the envelope, labeled T, represents maximum opening of the mandible, or the translation endpoint. From here, closing of the mandible is achieved by two motions, a translatory movement from T to R, and a rotational movement from R back to centric relation. Now, as you guys know, CR is considered the most stable and reproducible jaw position in dentistry, and one that gives us a platform to build off of when we're doing a full mouth rehabilitation. And that includes complete denture therapy, especially when you have a patient who is a bruxer. Alright, the next movement from CR will be the MIP. And what you need to know is that this shift is essentially an upward and anterior mandibular movement. And if you position your own jaw in CR and bite firmly to go back to MIP, you'll feel yourself sliding upwards and forwards. So if you ever forget, remember, you're a human with a functioning jaw, so you can always try out these movements for yourself. Alright, next movement will be from MIP to the end-to-end position. And obviously, this is accomplished by the condyles translating forward and down the eminence. Pretty simple. Lastly, we have the anterior most point, which represents maximal protrusion. So all in all, from CR to this protruded position, you can appreciate the mandible moving forwards and downwards, since again, the condyles have to travel down the eminence. Okay, now let's take a look at some mandibular movements and some terms you need to be aware of. We can label the mandibular sides as either working side or non-working balancing side. Now, these labels are in relation to the direction of movement. So if the mandible moves to the patient's right, as we can see here, then the right side is the working side, while the left side is the non-working or balancing side. Another important thing to note is the movement of the condyles on the mandible. The left condyle, or the non-working condyle, moves down the eminence, while the right condyle, or the working condyle, rotates in place. And obviously, if we perform a left lateral excursion, well, then the left side becomes the working side, and the right side will become the non-working or balancing side. Again, take note of the direction of the condyles. The right condyle moves down immediately this time, while the left one simply rotates. The last movement we'll look at is the protrusive movement. Here, the whole mandible moves downwards and forwards, and so there's no working or non-working sides. Both condyles perform the same movement, so we don't have any special terms here. Okay guys, time to talk about articulators. There are two primary types of articulators that you've probably heard of. First, we have the Archon articulator. The Archon design mirrors the anatomical relationship of the human jaw, and you may wonder, what the heck does that even mean? Well, you know how our TMJs are connected to our mandible? Well, same thing here. The components that represent the TMJs, the two spheres you see here, are connected to the lower member of the articulator, which is representing the mandible. Archon-type articulators are useful for complex rehabs, especially when increasing the VDO, because they closely resemble real jaw function. On the other hand, we have the non-Archon articulator. The non-Archon design has a reverse setup, with the components representing the condyles, again the two spheres, being attached to the upper member of the articulator. So although this design is less anatomically accurate, it provides enough functionality for straightforward cases that don't really require us to play around with the VDO. Now, despite these differences, one important point I want you guys to remember is that maximum intracuspation position, or MIP, is identical in both types of articulators. And that should make sense because MIP is a static tooth-related position. It's really when you start moving around the members of the articulators that the differences between these two come to light. Another similarity between these two articulators is that they both require a Facebow registration for proper mounting of casts. There's a lot of different Facebow transfers out there, but they all have one goal, to capture the 3D relationship of the maxilla, or the maxillary teeth, to the TMJs. And this statement may seem simple, but in reality, obtaining the 3D relationship of two structures is pretty complex. It's essentially registering the orientation of the maxilla in relation to the TMJs in the horizontal plane, the vertical plane, and the sagittal plane. In other words, everything from the midline to the occlusal plane of the maxillary arch is recorded in 3D space and related back to the TMJs. This information is then transferred to the articulator in hopes of being able to better reproduce the opening and closing movements of a patient on the articulator. Now, there are two types of Facebows that can achieve all of this to varying degrees of accuracy. The first is the kinematic Facebow, which the vast majority of you guys have never seen nor will you ever see unless you go into pros. The kinematic Facebow captures the relationship of the maxillary teeth to precisely located points on the TMJ that define how the mandible opens and closes. It requires a prerequisite step of locating the hinge axis, which is a complex procedure that actually involves tattooing points on a patient's face. And I know that sounds crazy, but I always had fun doing this step. And admittedly, the whole process is very meticulous and difficult, but what you get out of it is extreme accuracy. And so this is reserved for complex full mouth rehabs. It's certainly not your everyday tool. Whereas the arbitrary Facebow, which is what you guys are used to, captures the relationship of the maxillary teeth to a convenient anatomic landmark that gets us close enough to the TMJs. And this arbitrary anatomical landmark is obviously none other than the external auditory meatus, aka the ear. So the reason we call it an arbitrary Facebow is because we're not actually locating the hinge axis. We're simply approximating its location by using the ear as a reference point. So this has the benefit of making the whole process much easier to perform in contrast to the kinematic Facebow, while still giving us some degree of accuracy. Alright guys, that's everything you need to know about mandibular motion and articulators. So let's reinforce everything we just learned with a practice problem. So the question reads, each of the following is registered with a Facebow except one. Which is the exception? Pause the video if you need some time, but the answer is C, the patient's vertical dimension of occlusion. Remember guys, the Facebow has nothing to do with the mandible. Its only focus is to relate the orientation of the maxilla, including the midline and the position of the occlusal plane, to the TMJs in different planes of space. VDO, or vertical dimension of occlusion, is a maxillomandibular or interjaw relationship. Alright guys, with that, we are done. Here's a quick summary of the high yield points we went over. Take a moment to pause and make sure you understand these concepts. Thanks for watching, and see you in the next video series.